give it a second, sorry about that. There we go, we're now recording. So sorry about that, everyone. As I was saying, welcome to this evening's lecture. Please do pop your hand up or unmute at any point if you have any questions. I can see one hand up. Is that accidental, or is that someone with a question? I'm going to assume it's accidental. All right then, so let's get started. So I've mostly focused this to the Oxford syllabus. Here it is. I'm going to try and cover as much of this as I can. So let's see how we get on. And as I say, we'll have some interactive questions through to check your understanding as we go along. So let's start off with an overview of cardiac function. So at sixth form, you will have learnt, well, at GCSE probably, you learned the basic route that blood takes as it moves through the heart. That's from the venous system, the vena cava into the atria, through into ventricles and out through the arteries. Obviously, you know that we have a double circulation. So for each complete circulation of the body, blood passes through the heart twice. Once from the vena cava through the right side of the heart and into the pulmonary arteries, through the lungs, back through the pulmonary veins, into the left side of the heart, and out into the systemic circulation via the aorta. You'll also have learned about the phases of the cardiac cycle. This is kind of what the heart goes through for every complete heartbeat to move blood through those chambers, atria to ventricle and then out. So first we have this diastolic phase where the heart is relaxed and blood returns from veins and fills the heart, mostly the atria. We then have atrial systole, which is where we get atrial contraction to actively fill the ventricles. That's to force blood through the valves and into the ventricles. You then have ventricular contraction, which is, a really strong muscular contraction to send blood into the pulmonary and systemic circulations out of the heart. And as you'll have learned many times, the left side of the heart has much more work to do than the right. So therefore, the left ventricle in particular has a really thick muscular wall compared to the right ventricle, just because of the different levels of resistance in the systemic circulation on the left and the pulmonary circulation on the right. I'm not going to go too much into the anatomy of all this. Obviously, we think about the valves in the heart and the different chambers. I think there is another lecture in the series about the anatomy of the heart, so I'm not really going to look into that any further. So thinking about the cardiac cycle again with some pictures which may help. We start over here on the left hand side, thinking about a fully relaxed heart with blood returning from the venous system, filling into the atria. And because the ventricles are also relaxed at this stage, we get some passive filling, which is where blood moves through from the atria into the ventricles. We then get atrial systole, which almost, if you like, serves to top up the ventricles and send that extra last bit of blood from the atria into the ventricles to ensure that they're completely full. We then have two phases of ventricular systole. This is new for undergraduate level compared to A level, but here we go, we can cope. And this is where in the initial stages of ventricular contraction, ventricular systole, the pressure within that ventricle increases and the atrioventricular valves are closed because of the pressure in the ventricles is now higher than that in the atria. However, the pressure in the ventricles is not yet higher than the arteries, than the outflow vessels. So though the aortic and the pulmonary valves remain closed. So what that means is you get contraction of the ventricles without any blood being able to leave. So pressure increases, but the volume stays the same, and we call that the isovolumetric phase. As the ventricles continue to contract, pressure increases until eventually ventricular pressure exceeds that in the pulmonary trunk and the aortic trunk, and that's when those valves open and blood is able to leave the ventricles and go on its merry way around the body, and that's what we call the ejection phase of ventricular systole. And then that's one complete cardiac cycle done, and we get diastole, during which atrial filling is able to begin again, but there is a little bit of a delay before the ventricles, fully relax, such that ventricular pressure falls again to be lower than pressure in the atria. So there is this short period where we get atrial filling without that passive ventricular filling that we talked about at the start. You will be familiar with hideous graphs like this, and I want to try and repeat what we've just talked about on this graph. So here goes. We begin in this green area here. I realise this might be a bit hard to see, but I hope you can, which is where we have passive filling of both atria and ventricles with the atrioventricular valves open. This is marked by I'm just trying to get my colours here. So the atria are in black and the ventricles are in red here. So you can see that you get passive filling, and the pressures in both the ventricles and the atria begin to increase together over on this left-hand side. We then get atrial systole here in yellow, where you get disproportionate increase in pressure in the atria because they're contracting, and that is transmitted through to the ventricles as blood moves through and tops up the ventricles, if you like. We then get ventricular systole, and this happens in two phases. First is that isovolumetric phase where the ventricles contract, but ventricular pressure doesn't exceed the pressure in the outflow trunks. On here we have the aorta shown. So you can see in this orangey phase, pressure in the ventricles, that red line increases really rapidly with contraction, but that is not yet transmitted through to the aorta because that aortic valve is not yet open. With the ejection phase of ventricular systole, we have opening of the semilunar valves, that's the aortic and the pulmonary valves, and we have blood flow out of the ventricles and into the arteries. And this is, you see here with that increase in aortic pressure as blood leaves the heart. Finally, we have that beginning phase of diastole where ventricular pressure and atrial pressure, ventricular pressure, begins to decrease as the heart relaxes, but it's not yet so relaxed that the pressure in the ventricles is less than in the atria. So then you get this decline in the red line, the ventricular pressure here. You get filling of the atria once again because they are too relaxed, and that's the pressure changes that we see on the graph here. And then the whole circuit, if you like, starts again with complete relaxation, and you get atrial filling with passive ventricular filling as well. Now, all of these pressure changes are associated with heart sounds, and this is what you hear when you put your stethoscope to a patient's chest. You auscultate their chest and you can hear the heart sounds. This graph here is another way, if you like, of depicting the pressure changes that we've seen on the left-hand side, and it shows kind of the vertical lines up represent those isovolumetric phases of contraction where you get increased pressure without, or decreased pressure without changes in volume because the valves are closed. And then the curved bits at the top of the bottom, they represent the points where valves have opened, blood is flowing, and therefore actually the pressure doesn't change so much, rather the volume. This graph and both these graphs are quite useful for considering where our heart sounds are going to fall. So that classic lub-dub heart sound that you hear in a healthy heart are associated with the atrioventricular and semilunar valves closing respectively. And these come heart sounds 1 here circled, which comes at the beginning of isovolumetric contraction. So that's when the ventricles begin to contract. The pressure is sufficient to close the atrioventricular valves, which gives you the lub, but not yet sufficient to open the semilunar valves into the aorta, say. We then get heart sound 2, which comes later in the cycle when we've had after the ejection phase of ventricular systole, and the ventricles begin to relax, and that causes closure of the semilunar valves, separating the aorta and the left ventricle, and the pulmonary trunk and the right ventricle, and that is that dub sound that you hear. So that's lub, dub. You may come across people talking about additional heart sounds, and these do exist. You can see them on the graph on the left-hand side. The third heart sound can come shortly after the second heart sounds, and is actually usually quite healthy. It's something that you see in young children a lot, also very athletic people. And it's because the heart is so toned, if you like, and compliant, that as the atrioventricular valves open during diastole, you get kind of like a rush of blood through that kind of pops against the walls of the ventricles and causes this little additional heart sound. Heart sound 4, which happens just before heart sound 1, is less healthy, and this is suggesting that you've got a really stiff heart. For example, you've had a heart attack, so you've got ischemia and scarring, or you've got diastolic heart failure, and this is where there's kind of it happens midway through, well, kind of at the beginning of atrial systole, and it's the idea that there's a sound created by the amount of pressure needed to force open the ventricles, and that creates a little sound. But heart sounds 3 and 4 are not as essential that you know about those. So how does this pumping function arise? Well, it arises through electrical activity. Myocytes are really special cells in that they can generate their own rhythmic contraction. And this is really important for that rhythmic contraction of the heart. This is the case for all myocytes in the heart, but is particularly important in bundles of tissue called nodes. That's because these nodes kind of govern the rate at which all the cells in the myocardium depolarize and contract, which is obviously really, really important to generate this lovely cardiac cycle that we need if we're going to have blood moving effectively through the circulation. And obviously, you know what these nodes are. They are the sinoatrial node, which is up in the right atrium, and the atrioventricular node. So these form an important conduction system. So the heartbeat in healthy people originates in the sinoatrial node, and we call that sinus rhythm. The sinoatrial node becomes the dominant pacemaker in the heart simply because it fires the fastest, and that gives you your normal heart rate of between 60 and 100 beats per minute. When the sinoatrial node depolarizes, a wave of depolarization spreads through the atria, and that gives you atrial systole. It is relayed to the atrioventricular node, from which the action potential propagates through the bundles of His and Purkinje fibers to spread up through the ventricles from the apex, and that's what gives you a ventricular systole. And it is the pause at the atrioventricular node that is really important for the timing of those two events with respect to one another. We can measure these electrical activity via an ECG. And at your level, it's really useful to be able to think of a 3-lead ECG, where you have one lead going directly across the top of the heart, lead 2 going kind of a diagonal in parallel to the heart if you think that the heart is displaced off to the left, and then lead 3 completing the triangle. I'm sure that you're familiar with the basic ECG. but I have included it here just to remind you. So you get that P wave, which is associated with atrial depolarization and systole. You have the QRS complex, which is associated with ventricular depolarization and systole. And you have T wave, which is associated with the repolarization of the ventricles. You don't get a wave with repolarization of the atria, really because it's masked by the QRS complex, which is a much bigger electrical activity. Always remember when you're talking about an ECG shows depolarization, not contraction. So this is a readout of the electrical activity that we can use to infer things about cardiac function. As you progress through medicine and into clinical school, you will spend quite a lot of time thinking about ECGs and how to interpret them and what you can learn from them. A few things that are kind of quite interesting to think about at this stage is the QRS complex and problems that can arise or changes that can arise when we have heart pathologies. So usually the QRS complex is nice and narrow to show a really rapid propagation of electrical impulses through the ventricles. And if we have a wide QRS, meaning that ventricular depolarization is slower, then that suggests abnormal conduction in the ventricles, which can be due to kind of a bundle branch block, or it can even mean that contraction, that the kind of impulse of ventricular depolarization isn't coming from the atrioventricular node and through those fibers, but it's actually arising in an ectopic bit of tissue somewhere else in the ventricle, which means that depolarization propagates slowly through the myocardium rather than through those really fast bundles that are designed, if you like, to propagate those action potentials really, really quickly. If you have any change to cardiac function, this is a good rule actually. If you have a change and a dysrhythmia of the heart that arises in the ventricles, so for example a problem with the sinoatrial node or an ectopic pacemaker somewhere in the atria, then we assume that the atrioventricular node is working well, and you will get a normal-ish QRS complex and it will be nice and narrow. By contrast, if you've got a problem in the heart that's arising in the ventricles itself, then a wide QRS is an important sign of that. So we've talked about gross electrical activity of the heart, but it's important as well to think about individual cardiomyocytes and what they're doing to generate this myogenic contraction. So this is you'll have seen many diagrams like this before. This is a quick reminder of kind of ion channels in the myocyte membrane. We call that the sarcolemma, but that's just the cell membrane. And the channels that set up a resting potential of around -80 millivolts. I'm not going to go into the nursed equilibrium in great detail because I think you will cover this elsewhere in other lectures as part of this series. But just to know that it's mostly determined by potassium. As in all neurons, it's the distribution of potassium ions at rest that determine the resting membrane potential of roughly 80 millivolts. So this is what a ventricular myocyte action potential looks like. So we get this resting potential of about 84, did I say before? Around 80 millivolts. And then you reach a threshold potential of roughly 60 to 65, and that triggers this action potential. So we assign names to the different parts of this. So phase 0 is depolarization, or the upstroke of the action potential. And this is where we reach threshold of -60 to -65. That's often due to kind of the propagation through Purkinje fibers and things that mean that adjacent cells depolarize, and that causes the next cell along to reach its threshold potential, and that's kind of how it propagates through the heart. But at this threshold, we get the opening of voltage-gated sodium channels, a rapid influx of positive sodium ions, and the myocardium depolarizes. I've added in red here some drugs or pharmacological compounds that we can use to inhibit these channels, because that's a question that they love to ask in the exam. So TTX and lidocaine block the voltage-gated sodium channel. I can see a question. I've just clicked on it and it's disappeared. Just to clarify, which electrolyte out of sodium and potassium will affect cardiac function the most? Both are very important. So potassium, we say, is the main determinant of the resting membrane potential. So that just means that when at that minus 80 millivolts, when the myocyte is at rest, potassium is the ion most responsible. The distribution of potassium due to the activity of channels in the membrane sets the membrane potential at around minus 80. Sodium is really important during the action potential, and you wouldn't get an action potential without both of them. But potassium is of particular importance at rest. And actually, when you later on in your careers, you will learn that if you have hyper or hypokalemia in the body, so that's an increase or a decrease in body potassium, then that is actually potentially very dangerous for the heart, because of the effect that it has on the resting membrane potential and on repolarization later on. So maybe you could argue that potassium is more important, and it will potassium going wrong will kill you first, if that's what you're interested in. So that's probably quite a long-winded answer. You're very welcome. So you have this upstroke called phase 0, and that's depolarization. You then get phase 1, which is this slight repolarization. So as the membrane depolarizes, we get voltage-gated potassium channels opening, and they open very briefly to bring the membrane potential back down a little bit, so that it sits between 0 and minus 20 millivolts. We then get this long plateau phase, which is very important in cardiomyocytes, because during this phase we have calcium channels open, in particular these L-type calcium channels, allowing an influx of external calcium into the heart. We can block these with calcium channel blockers, such as verapamil. As we will see shortly, calcium is really, really important in excitation contraction coupling, and ultimately makes the cell contract. And then as this plateau phase where calcium is entering the cell begins to taper off, and that's because over time we have these delayed rectifier potassium channels. That just means that they are triggered by depolarization but delayed, so offset, which is why the cell repolarizes much later on. So you get potassium moving back into the cell, causing it to repolarize and move back towards that resting membrane potential of minus 80. And amiodarone is a blocker of these channels. Carrying on from that question we actually had, so here again we see that potassium is very important, because it is the rate of entry of potassium back into the cell which determines how long the plateau phase of the action potential is. And you can get some conditions where a mutation in the potassium channels carrying that current causes an abnormally long plateau phase. We call this long QT syndrome. And this is a rare but important cause of sudden cardiac death in young people, and in kind of those anecdotal cases where you hear of really fit athletes who drop dead on the football field, probably have an underlying cardiomyopathy, we call it, a defect in their channels, usually this potassium channel, which causes abnormalities on their ECG and causes kind of an unstable heart rhythm. Just a very quick reminder, I'm not going to go through these, but these notes are in the handout. There are different techniques that we can use to record from these cells and learn about these currents. I, for the life of me, never understood these in first year, but thought that if I include the slides here, then you can read through those. and there's a diagram here as well, but I'm not going to dwell because we are a little bit time limited. So we've talked about ventricular action potentials, it's also really important to talk about the pacemaker of the action potential, sorry, of those myocytes that sit in the sinoatrial node. And we call this the pacemaker action potential. And these have this really rare, actually, tapered resting potential that when scientists first observed, they thought they were being hilarious and they called it the funny current, IF. And that is what is important for generating that rhythmic contraction in the heart. And when we say that the myocardium, that the heart is myogenic, that means that it can create its own action potentials and beat spontaneously without any external input. So this funny current is a slow inward current of sodium channels at rest. And it is mediated through these special voltage gated HCN channels. And that is, I forget, it's cyclic nucleotide gated. So they're regulated by cyclic GMP and things like that, is what the name means, but that's not important. So what it means is that instead of having that flat resting potential that is determined solely by potassium, you get this slow influx of sodium, which causes the membrane potential to slowly depolarize, or decay as it can be called. It's also helped by exchange channels and pumps as well, but really it's the HCN channel that's important. This means that regardless of, independent of any sort of input, the nodal cells trudge towards their threshold potential. They do it all by themselves. They're very clever. And so they inevitably reach their threshold potential of around -55 millivolts, which causes the opening of calcium channels. And that's an important differential, actually. The action potential of sinoatrial node cells is more dependent on calcium than sodium. The main rising phase and decay, that is. So we get two calcium channels involved. The first is this T-type calcium channel, which is a transient channel. And then that causes the membrane to depolarize a little bit when those L-type calcium channels that we've seen before also open, and that accelerates calcium entry and causes depolarization of the cell. Phase 3 repolarization is mediated by delayed rectifier channels once again. So you get potassium channel. So you get these potassium channels opening, the cell repolarizes, and over the course takes it back towards its resting membrane potential of around -80. But as the potassium channels inactivate over time, you get that dominance over towards the HCN channels and that funny current, which is predominantly sodium. And that's how you get this clockwork-like rhythmic depolarization of the cells, which is really important for cardiac function. It's not all about the pacemaker current. You will have noticed that the shapes of these action potentials are very different, and it's important to point out that long plateau phase in the ventricular action potential, which is really important for maximizing the amount of calcium that can enter the cell. Remember that calcium entry is via L-type calcium channels in the ventricles, and it takes place during that plateau period. And the reason that ventricular myocytes need to prioritize calcium entry is because calcium is really important for excitation contraction coupling. So as I've said, we get calcium entry via L-type calcium channels during the plateau phase. And this extracellular calcium really acts as a messenger, a second messenger we call calcium, remember, and triggers the release of more calcium from intracellular stores. And that means that with a relatively small calcium entry during that plateau phase, you can get a really large increase in cytoplasmic calcium in order to generate a forceful contraction. And we have You know, the cellular apparatus is adapted to allow this, so you get these invaginations of the myocyte cell membrane called T-tubules, where these L-type calcium channels are expressed. They are closely associated with ryanodine receptors, which sit in the membrane of the sarcoplasmic reticulum. The sarcoplasmic reticulum is packed full of calcium. We get calcium entry from outside through the L-type channel. That calcium binds to the ryanodine receptor, which causes more calcium to be released from those intracellular stores. So you get a huge surge of calcium, which causes contraction through actin-myosin cross-bridge cycling, and that's what creates contraction in systole. After contraction is complete, we get this calcium ATPase also within the sarcoplasmic reticular membrane, and that pumps calcium back into the sarcoplasmic reticulum in order for this cycle to repeat itself. And this is a very quick reminder of actin-myosin function in generating muscle contraction. Again, I'm not going to cover this in any detail here because I think there will be another lecture elsewhere in the series on how muscles work. So if you guys want to, then I do have some practice questions at the end of this first section of the lecture. I will share I've shared the link to Socrative. So if you would like to join, you're very welcome to. I've got 2 students in the room at the moment. If the rest of you would like to join, then you can. If anybody thinks strongly about it, we can just plough on with the rest of the lecture. So the first question, if you log in on your phone or on your browser, is the upstroke of the action potential is primarily determined by, and it's asking you which channel. If you just select at your will. Got 2 out of 4 answers. 3 out of 4, here we go. Amazing, so most of you got that it's the voltage gate and sodium channels. We had 1 person plumping for L-type calcium channels, which is a really great response, except from this is we're talking about ventricular myocytes at the moment. I should have made that a bit clearer perhaps. So this is for ventricular myocytes where the upstroke is mediated by sodium, but actually in the node, in the sinoatrial node, you're absolutely right that calcium is more important. Repolarization. Yeah, absolutely right. It is voltage-gated potassium channels, which are those delayed rectifier channels, which repolarize the membrane. Excellent. This is a bit of a tough one because I just flashed up those drugs, but if you can remember, have a go at this one. L-type voltage-gated calcium channels are blocked by digitalis, TEA, tetrodotoxin, vercuronium, or verapamil. Okay, yeah, a bit of a mix of answers. It is verapamil in this case. We're actually going to revisit some of the drugs in the next part of the lecture, so don't worry too much. Verapamil is a calcium channel blocker. What's the next question? And voltage-gated potassium channels, can you remember what they're blocked by? I realise this is harsh from just flashing them up. Yeah, amiodarone in this case. So verapamil is calcium, amiodarone is potassium, And then the last question here is your voltage-gated sodium channels, what are they blocked by? Yes, tetrodotoxin, which is that old favourite they mentioned in the lectures about pufferfish poison. If you like, at the end of the lecture, I will leave the Socrative thing open so you can navigate through those and look at the explanations as well. But if you remember tetrodotoxin, verapamil, and amiodarone, those are three really important agents which modulate calcium, potassium, and sodium channels. Let's carry on because I'm aware that we're 40 minutes in and I'm only about halfway through. I will try and pick up the pace, I'm sorry. Here we go. So autonomic innervation of the heart is really important in modulating our cardiac output and our heart rate. You get sympathetic innervation, which speeds up the heart and increases cardiac output. And you get parasympathetic innervation of the heart that slows it down. And there's a bit about the anatomy of those. Remember that the sympathetic innervation comes from the spinal cord through the sympathetic chain, whereas parasympathetic innervation is all about the vagus nerve. So sympathetic regulation of the heart does two things. It increases it's positively chronotropic, which increases the heart rate, and it increases the force of contractility or inotropy. So this is quite a busy slide, lots of animations, so sit tight and enjoy. So sympathetic nervous system releases noradrenaline. It also coincides with systemic adrenaline release from the adrenal glands. And the predominant receptor in the heart is the beta-1 receptor. It acts through a GS subunit to simulate adenyl cyclase, which produces cyclic AMP. Cyclic AMP acts on that HCN channel. Remember, it's the cyclic nucleotide gated channel to increase its activity and therefore shorten the duration of that funny current. CAMP also activates protein kinase A, which phosphorylates L-type calcium channels and delayed rectifier potassium channels to increase their activity and therefore speed up the action potential. There it is in words for your revision. So that means that depolarization and repolarization is faster, and that pacemaker current is also kind of steeper and shorter, which generates positive chronotropy. These A's, by the way, I don't know why they're formatted funnily. I think they're just arrows. They should just be arrows. So this gives positive chronotropy, which is an increase in the heart rate. You also get an effect through PK of inhibiting this protein called phospholamban. Phospholamban in turn inhibits that sarcoplasmic reticulum calcium ATPase, which is the pump returning calcium into the sarcoplasmic reticulum. So pKa in effect disinhibits that pump in order to increase calcium uptake, and it also acts directly at the ryanodine receptor to increase calcium release from the sarcoplasmic reticulum during depolarization. So what do these effects do? It basically means that more calcium is released with each contraction, with each depolarization, sorry, to create a stronger contraction, and then that is more rapidly taken back up. So that allows for a faster heart rate through this funny word of positive lusitropy, and it also increases the amount of calcium in the force of contraction, which is positive inotropy. You do also get this effect at the AV node as well, which you don't really need to know much about, but just to know that all of these together increase the rate and force of cardiac contractions. By contrast, parasympathetic regulation of the heart affects the heart rate, but less so the contractility. It doesn't really act on the ventricles as much. Oh, my animations have gone a bit funny. So remember that it's acetylcholine in the parasympathetic nervous system. This acts predominantly through the muscarinic type 2 receptor, which is GI coupled, and that inhibits adenylyl cyclase. So we in effect get a reversal of all of those processes that we saw before. So we get reduced cyclic AMP, which reduces the sodium current through the HCN channel. You also get reduced pKa activity, which results in less activity in L-type channels and delayed rectifier channels as they are dephosphorylated. So there's that in words. You also get this effect through this second subunit of the muscarinic receptor. Remember that these are all G protein coupled receptors with different subunits, and this beta gamma subunit actually acts directly at a kind of special type of potassium channel called these K-ACH channels. I guess it's acetylcholine, which relates it to the parasympathetic nervous system. This has this additional effect of increasing the amount of potassium that leaves the cell during repolarization, so that the cell effectively becomes hyperpolarized at rest. And that means that a longer pacemaker current, a longer duration of pacemaker current and sodium influx is required for the next heart rate beat to occur. And this effect in particular is really, really rapid. So the sympathetic system is a bit slower. It acts over, say, seconds to minutes, whereas the parasympathetic system can literally modulate the heart rate, you know, from beat to beat. And the net effect of all of this is you get slower depolarization and repolarization through the effects on the left-hand side of the screen, and you also get an elongation of the pacemaker current so that the heart rate slows down, negative chronotropy. This is a review of that. So sympathetic nervous system increases your heart rate. That's useful during physiological stress, such as exercise. If you are really, really sick and you have sepsis and your body goes into shock, then you will have increased heart rate, and in psychological stress as well, for example, an anxiety attack. The parasympathetic nervous system does the opposite, so it slows the heart rate down. This is kind of active most of the time at rest, to just kind of put a little bit of a brake on our resting heart rate so that it's closer to 60 rather than 100. And in trained athletes, that happens even more, which is why you can get really trained people with actually really, really low heart rates, kind of 30 or 40 sometimes. You also get kind of vasovagal effects, which is where you get a really slow heart rate with kind of activity in the vagus nerve. And this is seen if you go cold water diving and your heart rate goes really, really slow, or if you faint and you have what we call vasovagal syncope, which is really just a really slowing down and almost pausing of the heart when you faint. It happens to us all. It's quite harmless unless you bang your head. And remember that the dominant receptors are beta 1 on the sympathetic side and muscarinic type 2 on the parasympathetic side. So there's a whole host of drugs that we can use to modulate these systems in medicine. On the left, we have sympathomimetics, long word that I struggle to say, and these mimic the sympathetic nervous system. And we tend to use these when your cardiovascular system is compromised. So if your heart isn't working properly, we can try and give some of these drugs to increase your heart activity, if you like. And those include adrenaline, which you kind of give if you have anaphylaxis and your all your vessels dilate and you struggle to have a functioning cardiovascular system. Digoxin, which is used for heart failure and increases calcium availability. And also on the parasympathetic side, these parasympathomimetics are useful to slow down the heart if you have an arrhythmia, for example, and you get this classification of antiarrhythmic drugs, which we use in clinical practice, which you can see here. So class 1 is your local anesthetics, class 2 are your beta blockers. Beta blockers mostly act at that beta 1 receptor on the heart, and they are also used to lower your blood pressure. Amiodarone is the predominantly potassium channel. I know it says calcium here, but it's really predominantly a potassium channel blocker, and that's the class 3. And then verapamil is that calcium channel blocker. And all of these are used to treat various different arrhythmias. In addition to this, we have some self-regulation of the heart, if you like, and that's what we call the Frank-Starling law. And this is, again, a property intrinsic to the heart itself. It's not regulated by the autonomic nervous system. These are the experiments that allowed us to come up with the Frank-Starling law. And remember, that law is the idea that with an increased venous return, the strength of contraction and thus cardiac output will automatically increase, so that venous return to the heart is matched to cardiac output. So we had Frank's experiments, which you don't need to know, but if you ever wanted to write an essay on this, it might be quite useful. And he looked in the isovolumetric phase of contraction, so where the pressure is changing, but not the volume of the heart itself, to show that with an increased venous return, you get more pressure created by the myocytes. And then Starling did this, but kind of looking with a more complex setup, that when you increase venous return, you actually got a bigger volume returning to the heart, and that produced a bigger volume of cardiac output. This is it, blood pressure increases, and then the contractility, decrease. It contracts more. And the Frank-Starling law, as I said, is really, really useful because it matches venous return to cardiac output, which is very important for maintaining a complete and happy circulation. It's very precise, kind of on a beat-by-beat basis, and it generates this sort of characteristic curve that I'm sure you've seen before. So where with increased pressure, we get increased stroke volume and cardiac output. And that happens up to a plateau, beyond which the effect peters off, and actually over distension of the heart causes a decrease in cardiac output. Now, it's debatable whether a human heart in your body will ever get to the point where it is over distended, such that the Frank-Starling law fails, if you like. Some people, it might be quite nice to think about it if you have a dilated cardiomyopathy. So that's when you have a really large, thin-walled heart due to various underlying diseases. Then actually cardiac function is going to be much reduced, and part of that can be attributed to the Frank-Starling law and the fact that you move off over into this decay part. So just thinking about this kind of self-regulation by the heart, there are some consequences of the Frank-Starling law. And one of those is that actually you get this undesirable effect where heart failure can actually be self-perpetuating. And what we mean by that is if you have heart failure and therefore are not generating a cardiac output, the whole circulation system will fail, and your venous return will also reduce, and that means that through the Frank-Starling law, your cardiac output decreases even more. So where you have hypovolemic shock, so that's failure of the circulation system because of kind of dilation of the blood vessels and not enough venous return to the heart, you will have reduced cardiac output, which will perpetuate that shock. It's also quite interesting to think about lying to standing blood pressure. So this is kind of an assessment that we do quite a lot in clinic to measure the change in someone's blood pressure from lying down to standing up. When you stand up, obviously, blood pools in your legs and you get reduced venous return, and therefore your cardiac output decreases, and that causes your blood pressure to decrease to the extent where some frail elderly people will get really dizzy and fall over. Usually that is kind of corrected for by the sympathetic nervous system with kind of activation of your carotid baroreceptors, kind of stimulating the sympathetic nervous system to kind of prop up the heart rate, but in elderly people that can fail and they fall. And this is, I think they call this the Guyton Crossplot. And this is just I'm not going to go into huge amounts of detail. I don't think you need to either, to be honest. But this is just the idea that you have that Starling curve in red, which is the idea that venous return to the heart, here described as right atrial pressure, causes cardiac output to increase. And if you have sympathetic activity, then you get these stepwise changes, which are represented by the different red lines. So as you have sympathetic activity that increases the contractility of the heart, then the Starling law is kind of exaggerated and you get a stronger effect. And that is kind of superimposed on this filling function, which is the idea that depending on the capacity of your venous system, how distended or contracted it is, venous return to the heart is going to change. And therefore, it's the balance in these two systems that gives you kind of the crossover, which is where your cardiac output is going to sit at any given moment. I'm actually going to skip these questions, and for those of you who are keen at the end, I'm happy to stay around and do them, but I want to get through the next stage on hemodynamics, which is the last part of the lecture. I apologise that I'm overrunning a little bit, but I hope it's useful. I'll try and be done for about 10 past, and I hope that if you have to go, don't worry, but I hope that it's more use to kind of cover more of the topic. So hemodynamics is the physiological properties of blood flow. And if we think of kind of holistically, what's the function of the cardiovascular system? Well, it's to perfuse tissues, and for that we need blood flow. And blood flow is described by this law, Ohm's law. So Q, which is what Ohm assigns flow, is given by a pressure gradient divided by resistance to flow. So in this case, that pressure is provided by the heart. We call it hydrostatic pressure. And resistance is a property of the vasculature, which is kind of opposing the direction of flow, if you like. So resistance is given by Poussey's law. And this is quite a nice one, and it describes the properties of the vessels that impact on resistance. So what are the factors there? So we have fluid viscosity, which is a property of the blood that we're not going to go into too much here, but also the length of the vessel and also the radius of the vessel is really, really important. So they're the factors that determine resistance. And Laplace's law is a third law, which tells us the factors that determine the radius, too many R's. The radius of the vessel is given by Laplace's law. And the only reason really I've included this is to point out two things to you. So T, tension, is modulated by the contraction of smooth muscle within the vessel wall. And that is, so we can modify that. And also we have the difference between pressure inside the vessel and outside the vessel. Also contributes to determining the radius, and that's quite interesting very shortly when we go on to talk about pulse pressures. So some complex maths there that I never fully understood, but here's the simple version. Your blood pressure is determined by cardiac output on the side, but also resistance. So resistance within your vessels determines what your blood pressure is, alongside cardiac output and hemodynamic pressure. So resistance is determined by the diameter of vessels. That should say resistance is inversely proportional to vessel resistance, should say vessel radius or diameter. I'm sorry about that. And so number 3 therefore should read radius is proportional to tension in the vessel wall. That's a fun slide on my part. Sorry about that. So, and therefore, how do we regulate blood pressure? Well, we change wall tension. That's by the nervous system. That alters the resistance. and then that changes pressure, and that's how we regulate blood pressure and therefore can modify blood flow. So how do we regulate the smooth muscle and the radius of those vessels, or vascular tone, as it can sometimes be called? Well, we have some familiar faces. It's all pretty much to do with the sympathetic nervous system. So we have alpha-1 receptors, which are really, really important. They are the predominant vessels causing the receptors mediating vasoconstriction, and they're found on most arteries in the circulation. You also get some alpha-2 in the skin, but that's less important. Beta-1 is that really important receptor mediating sympathetic effects on the heart. And then beta-2 is found in some specialist locations, the myocardium, the heart muscle, skeletal muscle, and also in the liver. And that actually does the inverse effect. So that vasodilates in response to sympathetic activity rather than vasoconstricts. And what's the thought of that? Well, when we have sympathetic discharge, for example, when you're going for a run, then that shifts your cardiac output from kind of your general everywhere towards the heart and towards the muscles. So that's what's happening to your blood flow during exercise. It's shifted towards the heart and towards the muscles. And all the while, this vasoconstriction increases your blood pressure in the systemic circulation to increase the perfusion of all tissues, particularly those key critical tissues, the heart and muscle. You also get some local regulation of blood vessels, which is independent of the nervous system. And here are some important mediators involved in that. So you get nitric oxide, which is kind of produced in the endothelia in response to turbulent blood flow. So if you have really high pressure and blood kind of churning up, then the endothelium is going to produce nitric oxide, which diffuses a short distance to the smooth muscle cells within the arteries and causes that to locally dilate. And this is useful therapeutically for patients who have angina. And if we have stable angina, which is where you get kind of intermittent narrowing of coronary blood vessels, which causes chest pain, but not full-blown ischemia, as if you were having a myocardial infarction or heart attack, then actually GTN spray mimics the effects of nitric oxide. You take it under the tongue, and it vasodilates the coronary vessels to alleviate that hypoxia and stop the pain. And Viagra works the same way. To increase blood flow in the penis to overcome erectile dysfunction. We also get prostaglandins, which are local vasodilators, and they're really important when you have inflammation. And you'll learn next year that a hallmark of inflammation is increased blood flow to an area. And also you get adenosine, which shows its face when you have hypoxic tissues. They might be a bit damaged. They're unable to aerobically respire because there's not enough oxygen around, and therefore ATP begins to break down, producing adenosine as a byproduct. And that's kind of a safety net, if you like, to dilate out those blood vessels in areas of hypoxia and potential ischemia. It has different effects in the kidneys, but that's a kidney day, not a heart day. Brilliant. So that's kind of how we regulate blood pressure and flow. There's a couple of more things to think about with hemodynamics. One of these is this idea of pulse pressure, which I think we can cover really quickly. And that's, well, you all know what a pulse is. It's what you feel at your wrist. And fundamentally, you know that the pulse pressure is the difference in pressures between systole and diastole. However, it's not to say that it faithfully represents systole and diastole isn't quite correct, because actually the pressure changes that you get in systole and diastole in the heart are much greater than those that you get in your arteries. And it's important because if you think about it, otherwise you would have a burst of flow with systole and then no flow at all during diastole, a burst and then nothing. And that actually isn't the case. We have like a smoothing out of blood flow in the arteries to make it more laminar. How does that work? Well, that comes down to another property of arteries, which is that they have a high elastin content in their walls, which means that during systole, when you have really high pressure in the arteries, they bulge out and they expand, and some of that pressure and that energy is converted to kind of an elastic potential energy, if you like, so that during diastole, those walls can then contract and smoothen out the blood flow. And that's what gives you your kind of typical blood pressure of 120/80, when actually, strictly speaking, during diastole, pressure in the heart is probably lower than 80, kind of more towards 0. But that smoothing out is really important for kind of creating a functioning circulation all the time. And so pulse pressure is a word that we use to describe that difference. So if it's 120/80, then your pulse pressure is about 40. And if your pulse pressure is altered, so if your pulse pressure is reduced, then that can be a sign that your arteries are becoming kind of fibrous and less elastic. And for example, you might see that in atherosclerosis, and that can kind of predispose you to vessel damage or inadequate perfusion of tissues anywhere in the body, really. And it's also important to remember, I haven't got a slide on this, but remember that when you measure blood pressure, if you use like an old-fashioned, if you're manually recording blood pressure, you'll have learned about this in your lectures, but the idea is that you put a cuff on and you inflate that to above systolic blood pressure to cut off all blood flow downstream of that cuff on your arm. You then release the pressure slowly so that it comes below systolic pressure. And below there, you get those Korokov sounds, which is where systolic blood is able to force through the cuff, but diastolic blood isn't able to do that. So you get kind of a collapse of the vessel with each heartbeat, and you can hear that as a Korokov sound on your stethoscope. And then you keep lowering the pressure on your cuff until you fall below diastolic pressure, at which point this smooth laminar flow is resumed and you don't get the Korokov sounds anymore. So that's what we mean when we think about pulse, and this idea that pulse isn't strictly necessarily kind of 100% faithful representation of your heartbeat. Finally, it's important to think about, within capillaries. So we've talked a lot about arteries. We've talked very briefly about veins early on when we were talking about Starling's law and venous return and things like this. In your capillaries, we get this idea of Starling's law going on. So this is an important thing for you to understand. And this is what determines the balance of fluid movement between your blood and your tissues. So we have different pressures in play. So you have hydrostatic pressure, which is generated by the pressure of fluid inside your vessels generated by the heartbeat, which is pushing water out into the tissues. You get oncotic pressure, which is like an osmotic effect caused by having proteins within the blood vessel that want to draw water back in, because water will also always move to an area of increased oncotic pressure. And it's a careful balance of those two factors that determines how much fluid we get in our tissues. So in the early part of the capillaries, where hydrostatic pressure is higher because it's the arterial end, we get predominantly the forcing of water out of the vessels, and you get filtration and generation of tissue fluid. And then at the venous end, where hydrostatic pressure is reduced, we get primarily absorption of fluid. And the reason we absorb fluid is because proteins are retained within the vessel, and they therefore draw water back in at the venous end. And that red line on this graph kind of shows that balance of fluid movement. Having said all that, you still get a net pushing of fluid out into tissues, and that excess tissue, that excess fluid, sorry, is drained away by lymphatic vessels. If you have a problem with any of those variables that we have described, be that hydrostatic pressure, oncotic pressure, or your lymphatic system, then you will get excess fluid in your tissues. And something we do all the time in clinic is look at people's legs and press in on their shins. And where people have edema, so excess fluid in their tissues, you get this kind of pitting effect where the skin doesn't bounce back because it's kind of full of fluid. And so what can cause this? So if you have heart failure, you're going to have kind of loss of your circulation, and fluid will kind of will pool and accumulate in your capillaries and in your venous system, but your capillaries as well. And that in effect increases your hydrostatic pressure so that more water will sit out in tissue. If you have liver failure, then you're going to have reduced plasma proteins, which reduces that oncotic effect so that you're not drawing water back in. And therefore you can get this edema, and that's a really important sign in either liver or heart failure, actually. And then if you have obstruction or a problem with your lymphatic system, which is really common when people have had surgery or radiotherapy to remove a cancer, say, then you're going to get failure of drainage, and you're going to get a similar effect to this. So that really brings me to the end of the lecture. Please, please, please do go if you have to, but I'm also happy to sit for another 5 minutes or so and go through some more Socrative questions. I'm sorry that it's overrun, but I hope that I've covered a number of areas on your syllabus. This is what I think I've tried to cover. If you have any questions on these, then by all means do get in touch. I'm really happy to hear from you. There's a few gaps here, which I can adequately fill in here by just reminding you of the key figures and numbers that you need to learn for your exams. All right, so with that, I'm going to go. We'll stay around for a few moments to do the Socrative questions. Please do join if you'd like. If not, thank you very much for coming. Remember to fill in the feedback form because it really helps me. And you can also access the slides and the questions at the end of that form. All right, so I'm just gonna, got a few people still here, so let's have a look. If you guys want to have a go at this question. So we've got contraction of vascular smooth muscle is caused primarily by activation of the following receptors on the smooth muscle membrane.